Alright, this is the video for the pre-lab for the respiratory system, which is due on Monday, April 20th. Hopefully you've already done the pre-lab, and this is just for you to check your answers. Let's review some of the anatomy of the respiratory system. If we start right here through the nasal cavity, air enters into the nasal cavity, it circulates around the nasal concha, it's going to circulate around the mucosal epithelium here. And it's going to travel into the pharynx. We have the nasopharynx, and then it travels through the oropharynx, and then the air travels through the laryngopharynx before it goes through the larynx. And then after the voice box and the larynx, it goes into the trachea. Anything that is from the larynx after the larynx, starting with the trachea, this is all the lower respiratory system. Everything we talked about before in the head and the upper part of the neck, that's the upper respiratory system. And then we go through the trachea, and then as soon as the trachea splits at the carina, it goes into the primary bronchus, and then we're inside the bronchial tree inside of the lungs. We start with the primary bronchus, which splits into a secondary bronchus and a tertiary bronchus, and then the airways keep dividing or diverging and keep getting smaller and smaller until they get to the alveolar duct, which leads to the alveolus, and the alveolus is where we have gas exchange. The physiology behind air entering and exiting the lungs has to do with creating pressure that's higher or lower than atmospheric pressure. And the muscle that is used to create an environment that's lower than atmospheric pressure is the diaphragm. Whenever the diaphragm contracts, it pushes down into the abdomen and it flattens out. And when that happens, we're increasing the volume of the thoracic cavity. If you increase the volume of the thoracic cavity, then you decrease the pressure inside of the thoracic cavity, and then air goes into the lungs. And then after that, whenever the diaphragm relaxes, it pushes up into the thoracic cavity. So that is going to decrease the volume of the thoracic cavity. And anytime you decrease the volume of a container, you increase the pressure. So that raises the pressure above atmospheric pressure, so air will then leave the lungs. Question number 1 in the pre-lab. With what you have learned about pulmonary ventilation, how would you design an artificial respirator to keep patients with paralyzed respiratory muscles alive? How does artificial respiration by machine compare to mouth-to-mouth respiration? And on the slide, I'm showing an artificial respirator on the left-hand side, and then here is mouth-to-mouth on the right-hand side. So what do we need to do? We need to have mechanisms in place to move the air. Well, how does air move? Air moves because of pressure gradients. So the artificial respirator is going to create an environment where it's going to, whenever the pressure is above atmospheric pressure, air goes into the lungs, and then whenever they take pressure off, and then the lungs with their elastic recoil will then force the air out. Anyway, so what am I trying to say? The artificial respirator, it needs to alternate the pressure it generates between slightly higher than atmospheric pressure and slightly lower than atmospheric pressure. So when they squeeze on the bag or the pump of the respirator, it increases the pressure of air. Air pressure is going to be greater than the pressure inside the thoracic cavity, so then air is forced into the lungs. And then when you take pressure off of the bulb, then the pressure returns back to normal, and the pressure inside of the lungs is higher than the pressure outside, and that forces air out. So whatever we use in order to get air into the lungs, it has to be able to create pressure gradients. Now, how does that change with mouth to mouth? It really doesn't change. The principle is the same. Whenever you're blowing air into the patient's mouth, you're creating a pressure gradient to force air into their lungs. And then when you move away from their mouth, the elastic recoil of the elastic tissue of the lungs will then force the air out of the lungs. So the principle is the same, although one is definitely going to be a little more gross than the other. Before we get to the next question, we need to review a couple of concepts. These concepts are pulmonary ventilation and alveolar ventilation. Pulmonary ventilation is moving air in into out of the lungs per minute. What you do is you take their breathing rate, which is their ventilation rate, and then you multiply it by their tidal volume. And the tidal volume is how much air comes in and out of the lungs during a normal inhale and exhale. So you take the ventilation rate and then the tidal volume, and that gives you the pulmonary ventilation. Now, there are some places in the airways where there's no gas exchange. These places where there's no gas exchange is called the anatomical dead space. Now there's air coming in and out through the windpipe, but the windpipe does not have the alveoli or the pulmonary circulation in order to exchange gas. So the air inside of the trachea is considered to be an anatomical dead space. Now alveolar ventilation compared to pulmonary ventilation, alveolar ventilation is just the air that reaches and is exchanged through the respiratory membrane at the alveolus. So this is a more accurate measure. So what you do for the alveolar ventilation is you take the ventilation rate, and now you take the tidal volume and you take away the anatomical dead space, the space that's not used for gas exchange, and you multiply by the ventilation rate. So you take the ventilation rate, multiply it by, in parentheses, you take the tidal volume and you subtract the dead space, and that'll give you the more accurate alveolar ventilation. If we look at this chart here, this figure from the textbook, if we take the amount of air that's coming in and out of the lungs, it's going to be about 2,700 milliliters in this example. 150 milliliters stays in the anatomical dead space. At the end of a respiration, you have completely filled with 2,700 milliliters of air, and then 150 milliliters of that is going to be the dead space. Well, then what happens when you exhale? The first air that you exhale is going to be the 150 milliliters that was in the dead air space. So we first breathe out, 150 milliliters of the dead air space comes out, and then you have 350 milliliters of air leaving the lungs. That is going to be full of carbon dioxide and oxygen poor. And again, you still have air inside of the anatomical dead space. It's about 150 milliliters. And this is going to stay there, and it's oxygen poor air. So then you start breathing air back in. The first amount of air that you breathe back in is going to be the 150 milliliters that was in the dead air space. So then you start breathing in. First amount of air goes in is 150 milliliters. And then you breathe another 350 milliliters into the lungs. The last 150 milliliters stays in the dead air space. And then we're back at the beginning. So then whenever you breathe air out, the first air you breathe out is the 150 milliliters of oxygen-rich air that did not make it to the alveolus. So question number 2. Cindy is taking 14 breaths per minute. Her vital capacity is 3,000 milliliters. Her total lung capacity is 4,000 milliliters. Her tidal volume is 450 milliliters per breath. Calculate the following. And letter A says, please calculate Cindy's total pulmonary ventilation. So it tells you in this chart right here for total pulmonary ventilation, you take the ventilation rate and multiply by the tidal volume. So what is her ventilation rate? Well, that's her breathing rate. And it tells you right here she's breathing 14 breaths per minute. And you want to multiply it by the tidal volume. Does it matter what her vital capacity is? No. Does it matter what her total lung capacity is? No. That's just extra information. It does tell you the tidal volume is 450 milliliters. So you take 14 breaths per minute, multiply it by 450 milliliters, and that's going to give you an answer of 6,300 milliliters. All right, if you have any other thing, any number different, then you have to look see what you did. Take the breaths per minute, multiply it by the tidal volume, and that gives you the pulmonary ventilation, not the alveolar ventilation. Now, if the answer asked for it in liters, then how do you change 6,300 milliliters into liters? You move the decimal point over to the left 3 spots, and you have 6.3 liters per minute. That would be her pulmonary ventilation rate. All right, now let's look at letter B. What is her alveolar ventilation rate? In order to determine the alveolar ventilation rate, you take the ventilation rate, which again is still 14 breaths per minute, and now you take the tidal volume, and you subtract the dead air space. The average dead air space is 150 milliliters. All right, so to figure out her her alveolar ventilation rate, you take the 14 breaths per minute, and you multiply it by, you take the tidal volume, which is 450 milliliters, and you subtract 150 milliliters of the anatomical dead space. So that's going to tell you take 14 and you multiply it by 300 milliliters, and that gives you an answer of 4,200 milliliters. So earlier we had 6,300 milliliters per minute. Well, that adds up to 4,200 milliliters per minute. when it comes to alveolar ventilation rate. And again, if the question asked for it in liters, then it would be 4.2 liters. All right, so that's number 2. The next question is asking about Dalton's law. But what is Dalton's law? Dalton's law says that the total pressure of a mixture of gas or mixture of gases is the sum of the pressures of the individual gases. And then the pressure of an individual gas of the mixture is known as the partial pressure of the gas. In other words, if they give you the gases that are in a mixture, and according to Dalton's law, each partial pressure of these gases should add up to 100%. The thing about Dalton's law is that it is in dry air, not humid. If we're in a really humid environment, then you'd have to account for the water vapor of the gas. But we're not going to do that. We're going to keep it simple. We're just going to talk about in a dry environment. So the partial pressure of a gas would equal, you take the atmospheric pressure and you multiply the percentage of gas in the atmosphere. So if oxygen is 21% of the atmosphere, normal atmospheric pressure is 760. So you take 21% of 760, and that gives you a number of 160 millimeters of mercury for oxygen in the atmosphere. So we're going to have to do some math, and don't kill me for it. You can all do it. Number 3, there's a mixture of gases in dry air with an atmospheric pressure of 760 millimeters of mercury. Calculate the partial pressure of each gas for the examples below. So in letter A, we have oxygen at 20.7%, nitrogen at 78.2%, and then carbon dioxide is 1.1% of the atmosphere. So to figure out the partial pressure of oxygen in an atmosphere that is 760 millimeters of mercury, you're going to take 20.7% of it. Well, how do you multiply percentages? Now, some of you may have a calculator that can do that, but mine is just a simple calculator, and it cannot. You have to change that 20.7% into a number, and you do that by moving the decimal point over 2 places to the left. So you take 760, multiply it by 0.207, and that's going to give you an answer of 157.32 millimeters of mercury. All right, so let's look at it for nitrogen. It says nitrogen is 78.2%. So you take atmospheric pressure and you multiply it by 78.2%, which is going to be 7.782. And that gives you an answer of 594.32 millimeters of mercury. And then you take carbon dioxide. Carbon dioxide is 1.1%. So you take 760 and you multiply by 0.011, and that gives you an answer of 8.36 millimeters of mercury. Now, if you really want to check your answers to see if they're right, then you add up these 3 numbers. They should add up to 100%, or they should add up to 760 millimeters. Anyway, however you want to do it. I'm not going to go through letters B and C because it's simple math. We just did the first one. You take that percentage of 760. So on letter B, you take 45% of 760. That gives you the partial pressure of oxygen. And then you take 41% of 760, and that gives you the partial pressure of nitrogen, so on and so forth. The next question has to do with hyperventilation. So let's talk about what is hyperventilation and what is hypoventilation. Hyperventilation is whenever there's an increase in the respiratory rate. And whenever there's an increase in respiratory rate, that means you're going to increase the oxygen levels and you're going to decrease the carbon dioxide levels. Hypoventilation means there's a decrease in alveolar ventilation, which means there'll be a decrease in oxygen levels and an increase in carbon dioxide levels. Let's look at this graph or chart right here, showing you what happens with normal ventilation, breathing in, breathing out, your oxygen levels and carbon dioxide levels. With hyperventilation, when we go to the right of the graph, with hyperventilation, respiratory rate goes up, oxygen levels go up, carbon dioxide levels go down. When the carbon dioxide levels go down, that's going to affect your pH. It's going to raise your pH and make you more alkaline as your carbon dioxide levels go down. With hypoventilation, when you're not breathing or your breathing rate has gone down and there's not enough of a gas exchange, then your oxygen levels are going to drop and your carbon dioxide levels are going to rise. And when your carbon dioxide levels rise, then it's going to also affect your pH by making more acidic. Your pH will go down. So the next question, define hyperventilation and explain what may cause it. Is the increased ventilation that occurs while exercising an example of hyperventilation? And then explain your answer. How are the partial pressures of oxygen and carbon dioxide affected by hyperventilation? And can breathing into a paper bag remedy hyperventilation, or is this just unfounded folk medicine? Please explain. So like we saw a couple slides ago, hyperventilation, it is an increase in alveolar ventilation, and it increases or that exceeds your metabolic demand. So you're breathing in more oxygen than your body can use, and you're breathing off more carbon dioxide than your body needs. So a person, you can actually deliberately, on purpose, hyperventilate. And it may be because of emotional stress, or if you're at a high altitude, because whenever you're in a high altitude, oxygen levels naturally drop. So in order to compensate for low oxygen levels in the tissues, you start breathing more rapidly or faster. Whenever you are exercising, the increase in your breathing rate during exercise, it's necessary because you're creating oxygen debt and you have an increased metabolism. So this increased metabolism, which is making you breathe faster, this is not considered hyperventilation. Your oxygen levels are increased and carbon dioxide levels are decreased with hyperventilation because oxygen is more inhaled and carbon dioxide is more exhaled. And this produces an abnormally low carbon dioxide partial pressure in your blood. All right, so hyperventilation, they can be remedied by a paper bag treatment because you're going to be rebreathing your exhaled air so that you can increase your carbon dioxide levels and bring them back to normal so you're not alkaline anymore. Our next question, the graph below shows an oxygen dissociation curve with a normal curve in the center. What is the name of the phenomenon that shifts the curve to the right? And what causes this change in oxygen dissociation? And is the shift beneficial or detrimental? And then explain. If we look at this graph, let's see what we're looking at first. On the y-axis, right here, that is percent saturation of hemoglobin. That means how much oxygen is attached to the hemoglobin. And then we look at the bottom, down here. This is showing you the oxygen partial pressure in millimeters of mercury as we increase up here. Now if we look at the pH, our normal pH is 7.4. They want to know what happens if there's a shift to the right. Now if there's a shift to the right, the pH has been lowered to about 7.2. They call that the Bohr effect, B-O-H-R. So the Bohr effect is whenever there's been a shift in the pH to the right, and it changes your percent saturation. What does it do? That means that your hemoglobin is going to drop the oxygen faster. Is this beneficial or detrimental? This is actually beneficial because the normal cases of the shift to the right during Bohr is due to exercise. When you exercise, you increase your carbon dioxide levels and you increase lactic acid. Lactic acid is the byproduct of anaerobic respiration. All right, so with that increase in carbon dioxide and this increase in the lactic acid, it lowers your pH, which means it goes down to about 7.2. And it means that the red blood cells are dropping oxygen faster, which will be beneficial because the cells need them faster due to the increase in demand and due to the increase in metabolism. So in the question, what causes this change in oxygen dissociation? Has to do with, we answered that earlier when we said it had to do with your increasing carbon dioxide levels, increasing lactic acid levels. It decreases the pH. That's what causes the change in the oxygen dissociation. Is it beneficial or detrimental? It is beneficial because the muscles need oxygen faster if you're in a higher metabolism. All right, so look at this graph. I tried to get one as close as possible to the pre-lab, but it looks a little different, but it does have the same stuff. On the y-axis, we have the percent saturation of oxygen, just like we looked at before. And then on the y-axis, we have the oxygen partial pressure. And now what we're graphing is fetal and adult hemoglobin. And what does this matter? Adult hemoglobin is going to be the hemoglobin of the maternal blood, which is going to be the mother's blood. The fetal hemoglobin is from the fetus. Fetal hemoglobin is different from adult hemoglobin in that it has a bigger attraction or a bigger affinity for oxygen. And this is beneficial because as a fetus, you're depending on getting oxygen from the maternal blood. So the maternal hemoglobin does not have as high affinity for oxygen, so that whenever they come into close proximity, oxygen will switch. Oxygen will leave the maternal circulation and go into the fetal circulation, which is what we need to happen anyway. So, as the blood travels down the umbilical arteries and comes to placental arteries, it comes into close contact, but not actually in contact with the maternal blood. And so the oxygen can then be transferred across the placental membrane and into the fetal circulation. All right, so if we look at these questions, it says here, at a partial pressure of 80 millimeters of mercury, which type of hemoglobin binds more to oxygen? So we take this at 80. Which one is a higher affinity? Which one is a higher number? It's going to be the fetal hemoglobin. So fetal hemoglobin has a higher affinity for oxygen than maternal hemoglobin at 80, partial pressure of 80. Letter B, at a pressure of 40 millimeters of mercury, what type of hemoglobin has released more oxygen to the cell? Which one has released more? So if we look at 40, come up here, which one has dropped more? That would be the maternal hemoglobin. The maternal hemoglobin releases oxygen more readily than fetal hemoglobin at that oxygen pressure of 40. Letter C, explain the significance of the differences in fetal and maternal hemoglobin affinity. Well, the higher affinity of fetal hemoglobin for oxygen ensures that there's a net transfer of oxygen from the maternal blood to the fetal blood and the placenta. That's what I was talking about earlier. While unloading from fetal hemoglobin to fetal tissues is less favorable due to higher affinity, the high rate of oxygen consumption in fetal tissues and the consequent low oxygen pressure ensures that unloading will occur. All right, so that was letter C. Letter D. If a worm lived in low oxygen mudflats where the partial pressure of oxygen is 60 millimeters of mercury, which type of hemoglobin would it be better for it to have? So at 60, we're going to kind of go right here. Which one do you want to have a higher affinity for oxygen so you make sure that you can claim the oxygen would be the fetal hemoglobin? So letter D is the fetal hemoglobin. Now the last few questions on the pre-lab, I actually gave you the pages to look for them in the book or the website to go to find the answers. So number 7, what is asthma? And then it says please refer to page 556 in your textbook of the current edition. So that'll tell you that asthma is an obstructive lung disease. It is an inflammation of the airways, and it's often associated with allergies that results in bronchoconstriction and airway edema. So we're closing off and narrowing the airways, and there's going to be pulmonary edema. So there's going to be separation a little bit or increased distance between the alveolus and the pulmonary circulation. Now it can be triggered by exercise and rapid changes in temperature or humidity of inspired air. Asthmatic patients complain of air hunger and difficulty breathing or dyspnea, which means painful breathing. The severity of asthma attacks range from mild to life-threatening. Studies of asthma at the cellular level show that a variety of chemical signals may be responsible for inducing asthmatic bronchoconstriction. Among these are acetylcholine, histamine, substance P, and leukotriene secreted by mast cells, macrophages, and eosinophils. All right, so you're limiting the amount of air that gets to the alveoli in order to have gas exchange. Number 8, what are some asthma symptoms? And then what are some things that could make them worse? And then I'll give you the website, and literally you click on the spot that says symptoms of asthma. And then below that it says what makes them worse. All right, so there's wheezing, there's coughing, there's chest tightness, there's shortness of breath, and then things that make them worse. When you expose yourself to the triggers, when you expose yourself to allergens and pollutions in the air, nighttime, and then pregnancy are all things that could make your asthma symptoms seem worse. And then number 9, what are some treatments for asthma? And then again, if you go to www.asthma.com, and then it lays it out for you when you click on asthma treatments. There are many types of medications. There are some medications that will either reduce the airway inflammation, or there will be other ways in order to open up the airways to cause bronchodilation instead of bronchoconstriction. So there's basically 2 types. There's quick relief, and then there's long-term control. The quick relief is using a bronchodilator. Usually it's an inhaler. So breathing in through the inhaler, it could be a powder, it could be a mist. Either way, it's going to open up the airways and cause bronchodilation. So that's quick relief. And then if that doesn't work, you have the long-term control, which means you take oral medication. You take the oral medication whether you have symptoms or not. You take them daily. And most of them are anti-inflammatories like steroids, and they work by reducing the inflammation of the airway of the lungs, and they help prevent the symptoms, which is why you take them whether you're having an asthma attack or not. Now, the title of the case study for this is Asthma Attacks, and it's about a little boy who unfortunately has an asthma attack in the middle of the night. So email me if you have any questions. The pre-lab is due on Monday. Don't email it to me, just it's for you to do. But the case study itself is due the same day as the final. Your lab final is going to be Monday, April 27th. There will be a study guide which will be available to you starting on, I do believe, Tuesday the 21st.